professionals that are involved in the care of children and families living with cancer. Myself and my colleague here, Lucy, are two of the main team members curating the Children and Young People Student Nurse Network. We offer support and advice to child student nurses throughout the UK and share our knowledge. So the interview we're doing now will be shared onto the CYP Student Nurse Network social medias as part of our Childhood Cancer Awareness Week. That's a bit about what we're going to do. So let's just introduce ourselves. So I'm Melissa. I'm a student nurse, a third year at Salford University. I'm also a care support worker at my local trust. And hopefully, fingers crossed, I'm going to have a job at paediatric critical care.
So hi everyone, my name's Lucy. I'm a third year student nurse at Sheffield Hallam. Like Melissa, I do healthcare support shifts at some of my local trusts. And hopefully I'll be qualified next year with a job, and well, at the moment I'm thinking just the general peds ward.
Lovely, and my name's Bob Phillips. I am a part-time paediatric oncologist at the Leeds Children's Hospital, and part-time I am a researcher at the Hull York Medical School and University of York, where I work within the Centre for Reviews and Dissemination. And that is possibly the longest job title anybody in the universe should have. Also, I need to say it's not just general paediatrics. There is no just, I think, in the whole of medicine, but particularly in paediatrics. General peds is a massive mix that requires an enormous amount of breadth, understanding and depth around the complexities of a variety of conditions. So I would never just a generalist.
So should we start with the first question?
Go for it.
What or who inspired you to become an, I'll just say briefly, oncologist, if that's okay?
Yeah, you say oncologist, absolutely. Well, my interest in paediatrics in general was sparked when I was a medical student. I admitted a girl overnight who had quite bad asthma, and I was quite worried about her. And in the morning, she jumped out of bed. We were on the ward round. There's the professor, the professor's little friends, the doctors behind, and this little gaggle of about 50 medical students. Pushed down the ward, grabbed me, and did a cartwheel to show that she was much, much better, which was brilliant because, frankly, none of the old people I'd ever admitted had done that to me. But also, the professor of paediatrics just went, "Oh, well, tell us about this. You look much better, young lady." And it was such a different way of living than adult medicine that dragged me into peds in the first place. And then within that, paediatric oncology and hematology, which are closely combined in our world, use an awful lot of doing research and then putting it directly into practice. At the time that I was a medical student, over 3/4 of patients that had a new diagnosis were on a clinical trial to try and improve management. And that fluctuates through the years, but it's a very high proportion that are on clinical trials. And as soon as those clinical trials finish, it is put into action. There's no faffing around. There's very little variation across the country in the majority of treatment because it's driven by the best quality evidence being turned into practice straight away. And it's those things really that dragged it to me. The idea that you can use evidence, you get to meet families, you get to live with them, and really manage to help what they're doing as they go through a complicated but interesting sort of part of life from medical and psychosocial side.
Thinking back to when you were like a medical student, what's the one piece of advice you would give to current students, either like medical students or nursing students, that you think would benefit them moving, like as they begin their journey?
The two pieces of advice really that were offered to me that I think were really helpful. The first is dead obvious, and it's listen to the patient and the parents. They don't always tell you the truth, but the vast majority of the time they do. So listen to them. And the second is, it's the child that has the disease, not you. It's almost always the disease's fault, not yours, when things don't have the outcome that you want them to have. And you can feel, and possibly should feel, very, very sad when bad things happen. But it isn't usually, it isn't your fault. And to be able to feel that grief and sadness, but not have it overwhelm you, is a really important thing to be able to learn to do, because I think it is a learned behaviour, it's a learned skill.
Yeah, would you say that's something that you develop over time?
I think different people develop it at different times, and I don't think it's linear. I think there are times that I've had where things have got through to me, as in to me, in a way that they haven't at other times, and that must be to do, I think, with my personal circumstance at that point, how I was feeling with other stuff going on, that make them more or less impactful upon me. I wouldn't then expect, you know, if someone feels, oh, I've been here before, I'm losing it all. No, it's just that life wobbles on the whole.
Do you think you could share one of your hardest moments with us?
You know, that's really, really tricky, because they're normally about administration. The stuff that's around patients is hard, but the stuff that's really annoying and frustrating tends to be because the computer won't boot up, the biochemistry won't take something over, the forms have gone missing, the pod's broken, all the porters are trying to drag off a multi-car accident up on the roof, and it's administrative rather than the stuff that I guess your normal person thinks of would be the most stressful. The most distressing tends to be that. The hardest things I think I found as a doctor rather than as a researcher have been the times when there's been disagreement, not so much the times when I've had to talk to people about the fact that this is now incurable, or tell children that they've got a cancer, or that they go to intensive care, or that stuff is less problematic than being in a place where a family is at odds and one parent wants to do something and one parent wants to do something different, or there's been a very strong move to not be able to discuss something with a competent 13, 14, 15-year-old. And the parents don't want us to talk about what's actually going on, and they want to limit our language and our understanding with that. Those are the hardest times, rather than what the normal people might think of as being the hardest times.
That's really interesting that you've said that, actually, because I agree. I find things like environmental things go wrong on the wards, technology, everyone uses technology these days, but everything just gets delayed, waiting for the results. So yeah, I totally get where you're coming from. So would you like to share what a typical day in your life looks like?
Yeah, there isn't one, but to go for something that a couple of sort of typical days from my clinical or my academic, I get up far too early and I take the dog for a walk, and you can see Lotherton behind me, which is a lovely place to take the dog around. Starting the day with a nice stroll. It's not always sunny. Then get into work. Clinical work tends to be done in person still, so I'll go into the hospital and then I might run an outpatient clinic, where I see a dozen patients with either active cancers that are being treated or on follow-up, and new people coming through. The way that we work is we see suspected cancers, not always proven cancers, and we work through the diagnostic process with them. That will include all stages of the cancer journey. So there'll be that sort of diagnostic phase, there'll be people that are in treatment, there'll be people who are just coming off treatment, there'll be people who have relapsed, there'll be people who are being actively treated in that relapse situation, and those being treated palliatively, with the intent to improve the quality and to some extent quantity of life. And then there will be children that I deal with who are in the end stages of their life as well. After, say, a clinic like that, I might go onto the wards and take part in a ward round where I review patients that are downstairs. We have 3 wards. One of them goes up to about the age of 13, one from 13 to 18-ish, and then a bone marrow transplant unit where we do stem cell transplant procedures on a range of individuals, and I might have patients scattered around there or potentially scattered around other places in the hospital. And then I will do all of the admin that is related to that, the letters, the forms, the emails, the really, really tedious stuff. Yeah. A research day will also start with a dog walk, but it will normally end up with me being currently in my back bedroom or in an office at the university. And I'll have meetings with people about getting research studies up and going. I might be looking at the data that's coming out of some of the research studies that we've done, or I might be writing them up in usually 2 or 3 different ways. So I'll be writing for an academic publication, but I'll also be writing something that can be presented in public, and maybe writing something that is a written version for the lay population, which is usually families and children with cancer, or developing something like a script to do a short video explanation of the studies that we've been undertaking. It has to be said, there's quite a lot more coffee breaks in the academic side than there is in the clinical side.
I was going to say, it sounds so busy. So what do you do for self-care?
Dog walking, which I am not allowed to call anything else. Yeah, no, I go dog walking. I pop to the gym with me lad. Sometimes ironing actually is remarkably therapeutic. And so I do a lot of ironing. I do the whole family's ironing. And so the fact that you can actually do ironing, and you can do, at least in your day, you've made something neat and tidy, and it's worked, which is not the sense in academia most of the time. And I watch rubbish telly as well. Yeah.
I'm a cat lover personally, to be honest. I've got 2 cats. They're like my babies.
Yeah, we've got cats here as well, but I shut the door so they're not invading today.
So you've just been telling us about your very busy day at work. So when you do get a lunch, what's your favourite thing that you like to eat?
Whatever's there. I mean, frankly, I'll just eat. If it's food, I'll eat it. Yeah, very definitely. But if someone was to offer to take me to one of the sushi bars in town, I might have to actually give in and then get out and leave whatever it was that was necessary to go and eat sushi. That would be really nice. Yeah. Or steak pie and chips. That'd be good.
I'll have to bring it over to you.
Yeah.
We do get pizza sometimes, Domino's.
Yeah. Oh yeah. Actually, so when I'm on call, once a week before the pandemic, and when we were allowed to actually sort of eat together, Teenage Cancer Trust would do a takeaway night once a week. So we might end up with a bunch of pizzas or takeaways from round and sort of have all the inpatient teenagers clumped around nattering. It was quite nice.
If you wasn't going to be an oncologist, let's say you started again, what would you want to do?
A professional dog walker.
You really do love dogs.
Yeah. Within medicine, what would I do? It was always a sort of a 3-way split between paediatrics, care of the elderly, and psychiatry. And so it would probably be care of the elderly would be the other alternative. Because within all of the grown-up specialities, if I didn't do peds, then that's the one that incorporates the same stuff, really.
Yeah.
Basically, a bunch of patients that nobody quite cares about, really. And there's complexity in sort of both the medical and the psychosocial, and it's working in a massive team. Doesn't quite have the same way that it puts research into action, but that's not its fault. So it would be there that I would probably end up.
Would you say the elderly are similar to peds in relation to the different ages you've got to look after? So, you know, in pediatrics, you've got babies, you've got infants, you've got older children, teenagers. There's quite a lot of variety, a lot of different vulnerabilities. So would you say they have similarities in that respect?
There is in sense, and I think there's many sorts of similarities, but care of the elderly can be a range of frailties. Yeah. As you go forward, and similar in the way that there's often a greater engagement than just with the patient. It's much more broadly the patient and their family.
Could you tell us something in your career that's given you the most joy, most happiness?
Oh, crikey. Again, it's one of those things that's really difficult to pin a single incident on. The sort of things that do bring me joy are when I hear that people have done something that's important to them, and that might be going to school, it might be standing half naked under a waterfall, or throwing themselves out of an airplane, or managing to get through the entirety of a film without falling asleep. It's about when people have done something that matters to them. And then from the academic side, it's knowing that the research that we've done has made an active difference. So in the pandemic, we've done a lot of work on how to get kids out of hospital quicker when they have febrile neutropenia, so fever, low neutrophils, immune suppression, might have a serious infection. A classic way of treating them is just to lock them in hospital and only let them get out when you're absolutely certain that everybody's all right. We know that that's overkill. And we've done loads of research in trying to separate out those that could go home earlier. Pandemic came along, and there's an enormous explosion in people wanting to get kids out of hospital. We managed to put that research into action and really change the way that people work and got people home sooner. And that sort of thing, where you see your efforts actually making an impact, that's the stuff that brings the joy and the desire to keep on going.
So I've got a question in relation to COVID, actually. So we know that children are vulnerable anyway when they're poorly, and then children with cancer perhaps are immunosuppressed because of treatments. So how has COVID affected them as well?
Well, that's really, really interesting, because right at the start of the pandemic, obviously, everybody was absolutely panicked. And there were lots of plans put in place for how we would reduce the treatment of people with cancer in order to not put them at risk of COVID and severe complications, including death. We set up a research study really quickly to capture every case of SARS-CoV-2 infection, which is the virus that causes COVID, in the UK over a period of over 12 months. In collecting that together, we found that even children with cancer, like children who don't have cancer, were not severely infected by the virus. And that information got into a continually updated parent-facing information sheet from CCLG, which is the sort of the biggest national cancer charity for children and cancer with leukemia. And that then increased our confidence and our understanding that what we needed to do was keep on treating children with cancer as intensively and not reduce the intensity, because the complications of SARS-CoV-2 were very minimal in comparison to what would happen if we'd have dropped the treatment of the cancer, which we're doing to save kids' lives. As we've gone through, we've found that that is still the case. Yeah, it's probably true that kids with cancer do get SARS-CoV-2, we've seen it, but it's the majority of them, the vast majority of them, have virtually no symptoms from it. And most of them we have captured because they've either turned up with something else, or they've needed an operation or something else, and we've done a routine sort of swab thing and found it. They haven't come in poorly as such with it. And getting that information, turning it round, putting it out there into the public area and putting it out to the parents and pushing it up to government has meant that through that time we changed the way that different children with cancer were categorized as the evidence emerged. What COVID did was it made a right mess of the services, because we had to move to masks and only having one parent in and having fewer people there. And then staff were going off poorly because of contacts or because they were actually unwell. And it changed the way that the rotas worked, so that people were being put into other wards and stuff. So it massively impacted our organization, but it didn't have a direct impact upon the children themselves. For me, the worst thing about it wasn't the virus, it was what we had to do to prevent that virus being even worse than it was. And I talked about this recently. One of the weirdest and still most difficult things is having a conversation where you have one parent in the room and one on a phone and saying, your kid's got cancer. They've got a particularly difficult sore that needs treatment in the next few hours. And I found that much more than the virus to be a really, really difficult thing to deal with.
I could imagine. It must be so challenging, especially as well with all the PPE. Yeah, it must be so difficult for parents as well. Sometimes people don't realise, do they, in CYP, that it's the parents as well.
Yeah.
You know, not being able to come and visit the children, not being able to be there when they're having ops treatment. So that's really interesting what you said, and true. Yeah.
Over time, it did change. It's better now than it was. In the first few weeks, the restrictions were so extreme and the exceptions were not understood and not applied that we had some inhumane situations occurring that required a lot of work, a lot of administrative work, a lot of emotional work to get over them. And we're in a better place now.
As students coming on to a placement with haematology and oncology, do you have any advice for us?
Yeah, it's utterly terrifying. We're all vicious and heartless, and we will attempt to physically rip you limb from limb. Yeah. If you don't know the CD markers for every single acute leukemia, we will just stare down our noses at you and ignore your very presence. But
that's me out then.
me as well, actually. I've only got a vague clue that they exist. What would my advice be? Get involved. Get involved. Do stuff. Don't be scared of the kids in front of you. On the whole, they're children. Yes, they've got central lines and no hair, but the more of them is a child than it is the cancer. And they are almost always willing to play and engage, and the cancery bit is sideways of them. I would also say, like with the whole of pediatrics, try really hard to learn the names that people want to be called rather than just using mum and dad. Try really, really, really hard not to use grandma or granddad in particular, unless you're absolutely certain it's the granddad and not the dad, because that's embarrassing. And just, kids are very good at responding to people when they bring their genuine selves. And if you don't want to do that or can't do that, then probably you need to be in a slightly different area. And that's fine, because it's about what's right for you. I couldn't be a surgeon. I find it difficult enough to try shoelaces. I can't cut open some walnut-sized heart and stitch you back together again. It's about skills, about where you are. But I think kids are very good at seeing through us more than sometimes with the grown-ups are. Or they're more willing to express that they're seeing through you. Maybe that's part of it as well.
What can we do as students to make a difference to children living with cancer?
Quite a few things. The first is when you get your placement, engage, enjoy, do it. The second would be share on all of your social medias and in conversations about the fact that children get cancer and that childhood cancer is curable in many cases, not in all, but it affects the entire family. So yeah, it's the child and their parents. It's their siblings as well. It's their grandparents, because the grandparents are both devastated for their grandchild with cancer, but they're often similarly hurt by the fact that their child is going through this as the parent as well. Remember that many families with childhood cancer, not all, but many families, are frustrated by people keep calling them brave, and try, if you can, not to use fight or battle metaphors unless they're expressly wanted by that family. For most families, they're not into the idea of my child fighting a cancer. There are some, but most of them don't. And many bereaved families in particular find that type of imagery extremely difficult. There have been a number of celebrities go through a cancer experience, and one in particular described how his experience was that he wasn't a warrior against cancer. That was complete garbage. He was the battlefield, and it was the healthcare team and the cancer that were having the battle, and he was just the field upon which it was being played out. And I thought that was quite a nice way of taking that metaphor and changing it, but also a description of what it must feel like to be torn apart with the armaments that we use, because nearly everything we do is toxic.
Thank you. You've been really insightful today. Thank you so much. Is there anything else you'd like to add, Lucy?
So we're doing like Cancer Awareness Week, as we've already mentioned. So I was just wondering if there were any like resources or like pieces of information that you would think would benefit either ourselves, like our followers, in any way.
Yep. So the Teenage Cancer Trust has got a really handy guide off there to the signs of teenage and young adult cancer, and particularly because many nursing students will still count as young adults.
Yeah.
Then that would be a great thing to share for the personal health of your followers, as well as stuff going wider into your careers as humans and nursing beyond. The CCLG has got links to a couple of projects that it's running called Head Smart and Child Cancer Smart, that are ways of raising awareness about the signs and symptoms of childhood cancer and encouraging people to continue to attend their GPs and EDs with things that they think might need checking out. Most of these signs are non-specific, they're vague, they usually have another cause rather than a cancer, leukemia, or a brain tumor, but they're worth looking at. They're not diagnostic, but they raise the awareness and they're worth looking at. The one that I think is most obvious and easy and really, really important to do is the lack of a red reflex in the eyes of babies. So when you have a photo and you get red bits, if you've got one red bit and one white bit, that needs checking out, and that needs checking out that week, because that can be a sign of eye cancer in babies. And it's very, very treatable if it's got the right type.
Fabulous, thank you. That's really helpful. Do you know the thing I was going to ask? Well, it's not really a question as such, but if our followers took anything from this interview, what would the main things you want them to get out of everything we've discussed today? If you could pinpoint it down in any way.
Try and make sure that you add some sort of exercise or joy in your life on a daily basis, and that will be the way to balance all of the rubbishy things that happen through your day, or it will be a way of helping you do that as you go through your day. And it doesn't matter what speciality you end up working in. Try and balance it out and make sure you love all of the bits of your day as much as you can.
I love that. Thank you. Okay, thank you very much for your time.
You.
No worries.
All right,
Bye.
then. Take care. Bye.